And so, like we all know, the Ministry of Health adopted the test and treat recommendation by the WHO, and that meant basically with the aim of increasing ART coverage among people living with HIV/AIDS. And this coverage, increasing the number has a strain on the few health workers who are already struggling in the public health facilities. So there was need for an innovative model that can actually put less strain on the public health workers, the few. So Ministry of Health also now went ahead and developed guidelines for delivery of chronic care using differentiated service delivery model as an innovative model to put less strain on the struggling health system, so that these increasing numbers of patients, we can find a way to relieve first of all relieve the health workers and then reduce the crowding at the health facility. So that's how they recommended came up with these guidelines. And I'm hopeful that you've looked at the differentiated service delivery model guidelines that have been developed by Ministry of Health. So that was, and when they did that, there was a period of trying to train the service delivery, the health workers. Because when they rolled them out, still the people did not take up the model. So the issue was, the intervention was to train the different public servants or health workers. So my question is, we want to, if the guidelines were available, the evidence is available that actually these differentiated service delivery models work, or the community ART delivery models work, why weren't the health workers taking them up? So the evidence exists, but the gap is the practice. Why weren't they taking them up so that they can start forming their groups? So my aim is basically to inform the process of implementation of the DSD models in public health facilities of Uganda, so as to facilitate fast adoption of the models. These models are being used in NGOs, TASO, MSF, and many others. Evidence exists, but in public health facilities, they're just being they're rolled out. So I want to inform that process. And so the objectives are very straightforward, like was it Emily's? To establish the proportion of health workers who report readiness to implement the DSD models following the training that was conducted, and then the proportion of patients who report readiness to receive care through these DSD models, and then the barriers and enablers for adoption of these models. So what's the theories? I'm looking at 3 theories. For objective 1 and 2, I'm using the stages of change model, or the trans-theoretical model, where people can be in the pre-contemplation phase, the contemplation, then the action, and then the maintenance. So part of the questions, which I'll not share here, is I'm aware about the model, and I want to implement. I'm ready to implement it. Or I don't know about the model. That's pre-contemplation. Already we are doing it. We have done it for the last 6 months. I adopted this from one of the papers that was giving us some questions you can use when you're implementing the trans-theoretical model to target, basically to assess readiness of an individual to change behavior, the target behavior. And the target behavior is basically for the health workers to start implementing these models. And then for the last one, I'm using the COMB, which people have already talked about, the capability, opportunities, and the motivation and behavior. So the study design, using the pre and post-intervention study design to collect both quantitative and qualitative data. Now, the issue with this project is that TASO already collected data before I did the submission to IRB. There was data before the training. We had actually planned to do it very fast, but the Ministry of Health said we must wait for them to roll out the training. And the intervention for you see, I'm using pre and post intervention. The intervention was the training of the public health workers. So we did the pre, but it's not part of, I can't say I sought approval, ethics approval. So what I'm going to do is basically to do retrospective, analyze that data that exists. So it's not that I'm collecting data now, then waiting for a period, then I take another data collection period. So we're using that, and we are looking at the 3 facilities, not junior this, we are looking at Tororo because this is where the TASO as an organization had collected data on the 3 facilities, Mukuju, Malaba, and the preliminaries where all this community engagement was done, met the DHO, met the health, all that had been done before, prior to the trainings. It's just that we took some time to wait until these facilities have been trained by the people who are recommended or mandated by Ministry of Health. So these are the 3 facilities, and the Tororo Hospital, a district hospital, a health center, 3, Malaba is 3, and then Mukuju is 4. So we shall look primarily at the health providers, but then we also look at the patients and the key personnel. So the training happened for all these facilities happened last month in some late Jan, others late early Feb. So now we've started the period of post-intervention, and the period we are looking at 6 months, the post-intervention period, and then we shall go back. So we are looking at only health providers who have worked in the ART clinic for at least 12 months, and then also for patients who have been in care for at least 1 year. And the exclusion is those who are newly employed. We shall not interview those, which we excluded when we were doing the pre-intervention. Then for staff, since there are few health workers in the ART clinics, we shall take all the health workers, because you find a facility with not more than 20 in the ART clinic, working in the ART clinic. So I've submitted this for the ethics, and I'm waiting for the response, and then after that we can now do the data collection. And this is that's the one for the post-intervention, because the pre-intervention data exists and was even already analyzed. I think that's maybe.
Thank you, Josephine. Questions, comments, observations?
This is a general comment. These differentiated care models, which have been affected by these stockouts, lack of drugs. Am I right? Despite intention to call it, premeditation, whatever. Some people might have intention, might have the willingness to go this way and practice differentiated service. But then, if you don't have drugs, for example, to give patients 3 months stable ones, or if you don't have treatments to take to the community, I don't know what do you think? How would they affect this?
I think one of the other things I'm looking at, that there are certain factors which we all know in the mind, but the documentation of these factors and which factors actually, there is even a variation in terms of the number. So you find that some facilities, when you're doing health system strengthening, you find some facilities actually, when you support them, they make orders in time. With the health system strengthening and an IP, IP, the presence of an implementing partner, we found that now many facilities are they are reducing the rates of stockouts, because if you TASO and you're supporting Tororo, when they restock out, you're actually accountable to see this, unless the stock out is really a big general thing. And sometimes there have been these movements of borrowing from this facility to see
No,
this.
I was saying, I know, for example, TASO, the private ones don't have a problem because they're supplied through,
yes.
through what? Cases. But the public ones have had a problem.
Yes, I'm referring to those public.
It's a national problem. I think it has nothing to do with your ability to order. It was a national.
Yes, and I'm still referring to those ones. You find that Mukuju will have TASO as an IP for now, and will have Uganda cares. Then you find for matters they have ordered and they are not supplying from NMS, the buffers from this keep them kind of going. So the stockouts, yes, exist, but the buffers from these IPs kind of keep them going. So you find a facility, not necessarily, the stockouts are there, yes, but because these IPs are trying to buffer. For some facilities, you find that there is some consistency, but not majorly from the government. So I'm trying to see if those factors, if it's really standard, if those factors are addressed, say the stockouts are not there, are there other factors that actually may hinder or may facilitate the implementation of this model? But I appreciate your comment that health workers are willing, they're just limited by many, I should call them national level challenges. Yes.
So maybe you want to assess those barriers in government
Public, yes.
facilities. Probably and inform the ministry. Probably, as Prof was saying, you see what has made it work in the clinics where they work. And that information may be adequate to know of those things which have made it work in that site. Are they existing in this site? And if so, if you want it to work, then you may need to address this.
Yes.
Because taking people to a room and training them about guidelines, it's just, it has been shown not to work. Because the environment in which you work plays a big role. People may have the knowledge, may have the skill. If you tell me now, examine someone's chest, I can tell you how to do the ABCD. But if I don't have a stethoscope to listen to anything, I may not put on the ear. So you see the tools are failing me to do, whether I know. So you go to one of the workshop and spend a week, and you come back, nothing changes. So that's what I'm saying. Those processes of drugs being available, other things which have made it work there. Maybe that information is just important, maybe to tell people that it may work or it may not work, irrespective of whether people are not resisting, but they don't know, they don't have the tools.
I think the two comments are related. I agree with you that certain things it's institutional system thing that may not be. But I'm also looking at if a facility is in a way supported and some of those system challenges are addressed, are there still issues that may hinder or may facilitate the fast adoption of the models?
Joseph, I forgot to ask you, sorry to dominate, but lest I forget, I forgot to ask you, are you going to do some cost effectiveness, cost stuff?
No.
You know when we talk about taking these drugs, either taking them out there or people coming to pick them from the clinic.
Yes.
Okay, some people have like delivery outlets. You have an outlet and you put the drugs there. Others, they take the drugs themselves and do outreaches.
Yes.
Others would say, oh, let
If
the
one
patient
friend.
come to the clinic.
Yes.
Those things need to be costed. There may be, when you put them to cost effectiveness, you might find the cost is different and not affordable to you. I know there was a time when I was on TASO,
What?
No, there
Steering
was a committee stuff. Center committees.
Center advisory committee.
And then the funders were saying, look here, it's very good for TASO to take drugs to patients,
Home.
and it is very expensive.
Yes. So that was the home-based delivery model, where we're delivering home. Now, right now,
But
TASO,
these models are the ones I'm talking about.
so-
Are they cost effective?
So right now, TASO, you can help me switch it off. Right now, TASO is doing a cost effectiveness analysis,
Oh,
but on only TASO sites, because most public health facilities have not actually rolled out. But it's only working on the TASO, the models within TASO, not outside TASO. So that's maybe the
no, I
closest.
wish in your study, don't worry, don't do it cost effective. But if you could collect the cost data,
The cost data, just
and
the
then,
costing.
and then somebody